All right. Well, thanks, guys, for staying. The room looks still pretty full, so obviously a lot of you had some questions about medical marijuana and its role in inflammatory bowel disease, which I think should prove to be an interesting discussion, and hopefully you guys take away at least some more information than you had kind of coming into this. I do have a couple of questions in sort of a non-electronic survey method. So how many people are taking care of patients that have brought up cannabis or marijuana in your clinic visits in the last month? So a large proportion of you. How many people have seen or have patients that have gotten better when they've been using marijuana or cannabis, meaning that they're coming in saying that they've never felt better because they're using cannabis or marijuana? So less of you. So this should be an interesting discussion, and I guess I have to figure out how to move forward. Okay. I have no relevant financial or relationship disclosure, so I'm not involved in any dispensaries related to marijuana, which is good. So I'll give you a brief outline just so you know kind of where we're going with this talk. I'm going to get you to know a little bit more about cannabis sativa, which is the more scientific name for marijuana or cannabis. We'll do a brief history lesson of how kind of medicinal cannabis has come to be what we know it today, and in terms of the legalization in the state of Illinois. Physician and patient views on cannabis, and then we'll also talk a little bit about what we know about cannabis use in our IBD patients. We'll look into the literature, which is not that many studies that have been done in terms of IBD use of cannabis, and then what can we go back to our clinics and tell our patients. So why should we even care about medical marijuana? Well, certainly it's of public interest. So if you look at this graph right here, and it may be a little bit blurry to you guys, but the dark green line basically shows how many people wanted in 1969 cannabis in general to be legalized. So it was to be illegal, or felt like it should be illegal. So it was a large percentage of people that didn't think that cannabis should be legalized. Whereas in comparison to 2013, there's a significant number of the public that believes that it should be legalized nationally, and not even just for medicinal purposes. When they looked further, they found that people actually felt that it maybe had the greatest benefit in medicinal purposes. So that's really the driver of this. Looking at some non-scientific data, if anybody's ever used Google Trends, you can actually look and see what people have been searching in Google over the last 5 years. And so there's been an increase in search in terms of legal cannabis or legal medical marijuana. You pick the search term, but over the last 5 years, been a significant increase in number of people that have been looking at it in the public. So the public clearly cares about medical marijuana, and there's a big push to legalize it nationally. Sanjay Gupta, who all of you know very well, and he thinks we should legalize medical marijuana, and he thinks we should do it nationally, and we should do it now. And I don't necessarily know that we have the data to say that that's really a blanket statement we should be making. So cannabis sativa is a plant, but as many of you know it as marijuana or cannabis. I'll refer to it throughout the talk. All of the terms are synonymous. But it's actually composed of hundreds of compounds. And these active compounds, hundreds of them are active in the plant, are phytocannabinoids. So these are different than cannabinoids, which are actually found within the body and are made within the body, but phytocannabinoids are plant cannabinoids. The two that you guys are probably most familiar with, and I'm not going to try to say the names because they're difficult to pronounce, but delta-9 tetrahydrocannabidiol, which is THC, so I'll refer to it as THC throughout the talk, and then cannabidiol, which is CBD, are the two that have been studied the most in terms of their medicinal effects in general. These cannabinoids, or phytocannabinoids, act at multiple endocannabinoid receptors, and I'll go into a little bit more detail about what these effects are clinically. And then some of you may know about two synthetic forms that are currently FDA approved as THC cannabinoids, and I'll go into a little bit more detail about these because I'm sure that there's some questions that you have about their use in inflammatory bowel disease. So the current available synthetic cannabinoids are dronabinol, which is also known as Marinol, so most of you probably know it as Marinol in the room. It's a Schedule III agent. It comes in a capsule form, and it's been FDA approved for the use in AIDS, cachexia, and chemotherapy-induced nausea and vomiting. It has, however, been studied in patients with diarrhea-predominant irritable bowel syndrome, and in these patients, they actually showed decreased frequency of bowel movements and overall improvement in symptom scores. So there has been one study that looked at this in IBS-related patients, although it is not FDA approved for that indication. And there have been no studies or even case reports to date of use of Marinol in patients with inflammatory bowel disease. On the other hand, there's the second agent, which is also a THC synthetic derivative, which is Nabilone, marketed as Sesimet. Schedule II agent, capsule form, was initially FDA approved in 1985 and unclear for what reasons, but took about 20 years to be marketed in the US. It's marketed for FDA-approved indication of chemotherapy-induced nausea and vomiting, although it is used off-label quite frequently for chronic pain and fibromyalgia. Although, again, this agent has not been studied in inflammatory bowel disease. So I know this is a busy slide, but it's a very complex interaction between cannabinoids and the endocannabinoid receptor system. So what are the clinical effects that we see with cannabinoids? Well, we see them through these effects of these two receptors, so cannabinoid receptor 1 or CB1 and cannabinoid receptor 2. And they're really distinguished about where they're located in the body. So CB1 receptors are most responsive to THC and are usually found within the central nervous system. And CB2 receptors are things that we think about in the peripheral organs, things like the GI tract. And those are most responsive to cannabidiol, although they put CBN, it's actually CBD based on what I had told you as the short for it. But these two things act together to give us the clinical effects of alteration in memory, potentially negative effects of acute anxiety. This is where we see sleep-related changes, and this is where potentially the effects of THC acting at the central nervous system, we get the pain control effects. So there have been some studies, and I'm putting question marks because the studies are either preclinical studies or they haven't been studied very well, is the direct GI effects of cannabinoids on these receptors. So alteration of permeability, which you can imagine could be of importance when it's related to inflammatory bowel disease. Changes in immune cell trafficking, also something that's of importance when you think about it for inflammatory bowel disease. And then alteration of gut motility, which they saw in the one study that was done in patients with irritable bowel. On the other hand, what are the potential IBD effects? And none of this is based on human data. This is all based on data that was done in mouse models. So there has been some potent anti-inflammatory effects with the use of cannabinoids in the mouse model. So I think that's where a lot of the thought comes from of how it could be beneficial in our IBD patients. It's a potent appetite stimulant, and many of you may not know why that is. It actually upregulates the olfactory system to make people want to eat more. So it's not necessarily, and it's probably helping with pain control, which makes people feel better and want to eat more as well, but that's where the potential effect comes in from the appetite stimulant. It's a bowel relaxant and has some anticholinergic effects, which you can imagine in our IBD patients could be very helpful. But we don't know what the effects necessarily are in our IBD patients that are human. We know what happens in the mouse model, but we don't necessarily know what's happening in our patients. So here's a timeline for at least the state of Illinois, and I think most of you are probably coming from at least this state, if not coming from my new state, Michigan. But here's the medical marijuana timeline. So about 5,000 years ago is when they first described medicinal purposes or medicinal use of marijuana in the Chinese population. So this is actually one of the, I think his name was Shen Nung was his name, and 5,000 years ago it initially described medicinal purposes for hemorrhage, vomiting, and parasitic infections. He actually self-administered most of the poisons that he tested, and they report in the Chinese literature that he died turning green. So I don't know if that was because he was using a cannabis-based derivative, but something of note. So it took many, many years for it to come to the United States. So in the mid-1800s, depending on the literature you read, it either came over on a boat from Ireland or it came over the border from Mexico. But either way, it was introduced to the United States in the 1800s. In 1850 is when we first see it described in pharmacopoeia as potential medicinal properties. In the early 1900s, so over 100 years ago, is when they first found the endocannabinoid system. So they found the sort of downstream effects of cannabinoids. In 1971, the Federal Controlled Substance Act actually made it a Schedule Class 1 agent, which meant that it was similar to heroin, so highly addictive with no potential benefit. So this is where it stands today in 2015 as well. 1996, California was the first state to legalize marijuana for medicinal purposes. And then many of you who are practicing in the state of Illinois probably wonder kind of what happened in terms of legalization here. So in 2013, August, so about 2 years ago exactly, it was signed into law, so it's the Illinois Medical Cannabis Patient Program. So this program became effective in January of 2014. But product is not available to patients, so patients can ask you to certify them as of January 2014. And many of you may have been asked already and may be certifying patients. But in November of 2015 is when they think that the first product will be available through dispensaries in the state of Illinois. So there is no product available at this time for patients in the state of Illinois. And interestingly, when Illinois did approve this law, they put it as a 4-year pilot program. So it will expire in December 2017 as it stands right now. So by the time product is available, there'll be a 2-year benefit potentially to patients that we think may benefit from this treatment. So it's legal in 23 states currently, and this is a map of the current states that are legal. The dark green is where it's legalized for medical purposes, and then recreational use is in the bright green. And then the blue is what's being added in the next year. So there's obviously a lot of states that have legislation that's pending to legalize. So this is as of June 1st in terms of legalization. So in the last month, I don't believe that there's been any other states that have legalized medicinal marijuana. But there's a disclaimer, still at a federal level, despite what your state does, it is considered a Schedule I drug under the Federal Controlled Substance Act. So it is at a federal level considered illegal, which has a lot of implications in terms of research. What are practitioners' current views on this? So Minnesota has done a couple studies looking at this, and they studied both patients and clinicians, and they basically asked them in the state of Minnesota when they legalized what their thoughts were in terms of who would be signing up. And so 70% of eligible patients would register for the program. On the other hand, when you compare this, 70% of physicians would not participate. So there's a lot of patients on board who want to benefit from marijuana use, but there aren't a lot of physicians that plan to participate in the program, at least in this state. When you ask physicians as to why, there's a large group of physicians that were surveyed again in Minnesota, who expressed concern about potential physical and mental risks and the limited evidence. And I think that that's probably the biggest the biggest reason that a lot of us maybe have hesitation is the limited amount of evidence in the diseases that we'd be using it for. The CCFA has definitely made a statement on this. So the CCFA does not endorse the smoking of marijuana by IBD patients, any current state-based medical marijuana program, or the legalization of marijuana. But what they do in their statement, what I think is important, is that they do support overall reviewing its Schedule I status, which is the biggest limitation in terms of why we have no literature, is because of its Schedule I status, it's hard to study. So if we can't study it, then we can't possibly have the literature, whether it's positive or negative. So the CCFA did make a statement on this. Are our IBD patients using marijuana? Many of us in the room can say yes, because our patients have come in and talked about using marijuana. There is a Spanish study, so obviously outside of the United States, where they have different, at least cultural views about the use of marijuana in different countries, but Spanish study reported use in about 10% of patients. There was a large Canadian study that found 50% of patients had prior use and 15% were using it currently. And the majority of the studies that have been done both in the States and out of the States have said that patients are using it to relieve their IBD symptoms, and the most common cited symptom is pain. But in this study from Canada, what was interesting is they actually showed it was associated with a lower quality of life. So despite the fact that patients were using it, they actually had reported lower quality of life scores when they looked at users versus non-users. I think the most striking evidence that has come out against the use of marijuana or having our patients use marijuana in Crohn's disease is the Canadian study that found that cannabis use in the last 6 months was associated with surgery with an odds ratio of over 5. They did a really good job controlling for certain factors that were predictor for surgery, like smoking status and duration of disease, but they did not control for disease activity, either clinical or objectively. So I think it's hard to really interpret that odds ratio, but to give you an idea, if you look at the odds ratios of smoking and patients who smoke and associated for risk for surgery, it's an odds ratio of anywhere from 1.5 to 3. So this is scary to think that patients that are using marijuana are going to be significantly more likely to have surgery. But I would like to see that controlled for disease activity. Briefly looking at the 2 studies that have been done in the United States, there was a study out of Boston that looked at marijuana use in both Crohn's and colitis, and they found that about 12% of their patients were users. About 50% were never users, which is similar to the previous studies outside of the United States. They felt that majority used, and they cited marijuana as being very helpful in relieving their pain, again, pain coming up, nausea and diarrhea. And the marijuana in their population was associated with younger age, and chronic abdominal pain. So again, chronic abdominal pain being the key theme here. In the study that we did at University of Chicago and Northwestern, looking at patients with Crohn's and colitis, we also found that there was about 50% of patients who never used marijuana. But in our patient population, we found a little bit higher percentage. So about a quarter of our patients reported current use of marijuana. And it's possible we got a response bias, that more patients were willing to participate because they had either had exposure recently or in the past. But we still had a similar never use in at least our population. We found that marijuana was associated with younger age, male gender, single marital status, and daily abdominal pain, again, pain being the key feature there. We've also found that there was no association with disease or severity of disease, and we defined a severity of disease using clinical indices, which we heard a little bit today, maybe not the best way to be defining disease activity. So what's the data? And I'm gonna go through these slides a little bit quicker just so that we can all get out of here and enjoy the weather. But what is the role in digestive diseases in general? So there was a really great review that was done in the American Journal of Gastroenterology in the last couple months. I think it came out 2 months ago. And although there's significant preclinical data saying that the use of cannabinoids in digestive health has significant benefits, we're looking at the 6 trials, randomized control trials that have been done looking at marijuana use in digestive illnesses. So there's 6 trials that have been done. And if you pay attention to the numbers in these trials, we range anywhere from 6 patients to 164 patients. So we think about some of those studies that have been required to FDA approve a lot of the medications that we use in our IBD patients that have thousands of patients in them. These are very, very small numbers. So we're basing data on very, very small numbers. Many of you probably remember getting this journal in the mail. Clinical Gastroenterology and Hepatology put a nice cannabis leaf on the front of their cover in October 2013. And it was really to highlight one study, and it's the randomized control trial that was done in IBD patients. But the initial sort of studies that led into that randomized control trial were small observational-based studies, one that was done in Israel. And it looked at the benefit in Crohn's disease patients, and they found that overall, patients had improvement in symptoms. And again, we're going back to symptoms again. We haven't really seen any objective data showing improvement in inflammation. Patients overall felt better, so the quality of life was a little bit different in these studies. And they had a decreased need for steroids, which is, of course, an important endpoint. But the question is why? So Naftali and colleagues are the group in Israel that did the randomized control trial, and it's the only randomized control trial and probably the trial that has been quoted most by your patients who are coming in and saying that there was this one study that was done that showed benefit. And I'm going to argue that maybe that's not the case. So it was a small study of 21 patients with Crohn's disease. They defined disease activity as a CDAI of 200 to 450. So to get into the trial as active disease, you did not have to have any objective markers. These patients were heterogeneous in the fact that they had failed anything from a 5-ASA all the way up to anti-TNF-based therapies. Many of the patients were steroid dependent. They were randomized 1-to-1 to either receive smoked cannabis versus placebo, and the primary outcome of this study was to look at clinical remission at 8 weeks, and that was defined as a CDAI less than 150. The secondary outcomes that they looked at were a change in CDAI of 100, and the first time we were looking at objective markers, a decrease in the CRP level, and an improvement in quality of life. So to synthesize the data, and they had a lot of graphs in the paper, and you can refer to the paper for more detail, but basically looking at the primary outcome of clinical remission, so a CDAI less than 150. If you look at the study population versus the placebo population, there were a significant number of patients, the N is 11, remember, that had a clinical remission at 8 weeks when you compared it with placebo, but it was not statistically significant. So although there was 45% of the study group that was in clinical remission at 8 weeks, they did not meet statistical significance. When we look at some of the secondary outcomes, and I'm going to go quickly through this, these objective markers looking at hemoglobin change at 8 weeks and CRP change at 8 weeks, these were negative. So they didn't see improvement in either group of placebo and study group. So it failed to meet its primary endpoint of clinical remission at 8 weeks. And I'll go through, it did meet a few of its secondary endpoints. And there were no changes in objective markers of inflammation. So patients felt better, but there was no evidence that it improved their disease activity. So to summarize, this study had a couple positive. There was a large percentage of patients that at 8 weeks were able to obtain clinical remission. It did have improvement in quality of life scores, and patients were able to stop steroids or opiate therapy, which I think is a really important thing to note, is the stopping of opiate therapy. But there were no differences in objective markers of inflammation. All patients had a relapse either after stopping treatment or placebo, and it's a very small study with only 21 patients. And even though this is coming from the authors, based on the available data, one cannot argue that cannabis is a successful treatment for inflammatory process in Crohn's disease. So can cannabis be harmful? So it doesn't really seem to have a lot of benefit in terms of disease activity. It can make patients feel better, but can it be harmful? So overall, it actually has a pretty good safety profile, although there are some concerns in multiple fields of long-term use. So first, there's acute effects. So is this the patient with underlying anxiety comorbidities with chronic pain that you really want to have to start smoking daily cannabis? It can cause psychotic symptoms in patients who are susceptible. It can lead to delayed psychosocial development in adolescent patients that start it, decreased fertility, especially in men, increased risk for motor vehicle accidents, which I think is probably the most concerning, withdrawal symptoms, and then hyperemesis syndrome, which I'm sure many of us in the room have seen at least one patient who's come in on daily marijuana use who comes in with the difficult to treat nausea and vomiting. But there have been no deaths associated with marijuana use alone. So that doesn't mean marijuana use in motor vehicle accidents, but marijuana use alone has not been associated with any deaths. Briefly touching on cannabis hyperemesis syndrome, this was first described 7 years ago. Symptoms include cyclical vomiting, abdominal pain, and nausea. Risk factors are daily use of marijuana and obviously how long you've been using it. These patients often find that taking a hot bath or a shower can actually relieve their symptoms, but truly the only treatment for this is cessation of cannabis use. So we do see these patients, and we can see this associated with daily use. So there's still so many unanswered questions, and I probably didn't answer your question whether or not you should be using this in your IBD patients, or maybe I hope that I did maybe answer that. Are there any high-quality studies evaluating long-term outcomes in these patients? There aren't. And so we give a lot of medications that have outcomes data, and this doesn't have any outcomes data. Does the strain of marijuana matter? So when you go to these dispensaries, at least in other states, there's hundreds of strains that you can use, and they have different THC and CBD percentages or ratios. So I imagine if there's different THC and CBD ratios, it can have different clinical effects. So the strain may matter. Does the route of administration matter, whether patients smoke it or they use an oil or they're ingesting it orally? It actually has a longer half-life when it's ingested orally. So the route may matter. And so there's a lot of heterogeneity that would happen if you did start to study this because it's not just one compound. How often should patients be using it to obtain that desired clinical effect? We don't know that, and we don't know that based on the studies. There isn't sort of a prescribed dose. How can we apply controlled data to real-life use? It's very different. Naftali's study used genetically similar plants that were grown. That's not what our patients are necessarily getting when they're going to a dispensary. What are the indications that where it might be helpful? I don't think that inflammatory bowel disease alone or Crohn's disease alone, but is it helpful in the patient without active disease that has chronic pain that's requiring daily narcotics? Is that a patient that you may want to consider using this in? Why aren't our patients asking about FDA-approved synthetic derivatives like Marinol? They're not FDA-approved for the indication of inflammatory bowel disease, but if the true benefit is coming from the THC with reduction in pain, maybe this is a possible alternative to using smoked cannabis or marijuana. And what are the legal implications for physicians and patients? So there's some supplemental slides that I'm happy to email you if you send me an email in the state of Illinois that kind of go through the legal implications for you as a physician. And it's similar to prescribing narcotics, but there are legal implications that you need to think about when you're certifying patients. I think the bottom line here is that we need more high-quality studies evaluating efficacy and mucosal healing and outcomes, and we don't have that due to the current Schedule I status of marijuana in the United States. So the bottom line, there's clearly not enough robust controlled data to suggest a role of treatment in patients, or at least all patients with inflammatory bowel disease. And I might suggest that there's a possible adjuvant role to approved medical therapy in a select group of patients with Crohn's disease with chronic pain. And then there's my email. I'm happy to send the Illinois Medical Cannabis Patient Program supplemental slides that I put together with a lawyer who is actually part of the program in terms of getting it together, so that you guys had some more information about the legal implications. Thank you.